Welcome to the Hospital Medicine Unplugged podcast. Today we're diving deep, really deep, into the syndrome of inappropriate antidiuretic hormone secretion, SIADH. Our goal here is to pull out the most practical, actionable insights from the very latest literature. We're talking invited reviews from top journals like the New England Journal of Medicine, JMA, and focusing squarely on evidence-based diagnosis and management for our patients, the ones we see every day in the hospital.
That's exactly right. And, for our colleagues listening, this really is meant to be essential. SIADH is probably the most common electrolyte issue we grapple with day in and day out. But its management, well, it's got nuances. Especially when we think about moving beyond just fluid restriction, which, let's be honest, often doesn't cut it. We really need to understand the latest consensus on those second-line therapies, making sure correction is both effective and crucially safe.
Okay, so let's ground ourselves first, the definition. Getting this right is fundamental. It really dictates everything that follows diagnostically. So SIADH, syndrome of inappropriate antidiuretic hormone secretion. It's a disorder where you have this non-physiologic, persistent secretion of antidiuretic hormone, AVP or vasopressin, and the downstream effect, impaired renal-free water excretion, which leads ultimately to dilutional hyponatremia.
And that word inappropriate is absolutely critical. It's the linchpin. The key distinction, the thing that really helps avoid misdiagnosis, is remembering SIADH is, by its very definition, a euvolemic state. AVP release is happening without the normal triggers. The patient isn't a hyperosmolar, they're not volume down, not truly, so the kidneys are hanging on to water inappropriately, causing the low sodium, but without signs of fluid overload. If you see pitting edema, or conversely clear signs of dehydration like poor turgor or orthostasis, you really need to think about other diagnoses first, not pure SIADH.
Right. And why does this matter so much clinically? Well, hyponatremia itself is just incredibly common in the hospital setting. I mean, figures suggest up to 35% of all inpatients might have it at some point. It's the number one electrolyte abnormality we deal with. And when you look closer at that huge group, SIADH is responsible for a big chunk, maybe 25%, even up to 40% of those cases, especially in our older patients, the ones with lots of other medical problems.
Exactly. And the impact isn't just, the sodium is low. It goes way beyond the lab value. Even what we might consider mild hyponatremia, say the sodium of 125, 126, maybe even asymptomatic. It's independently linked to longer hospital stays. It's linked to higher readmission rates, more resource use overall, and, quite concerningly, increased mortality. We tend to focus, naturally, on the acute, severe cases with seizures, but we often miss the more subtle damage from chronic SIADH.
Yeah, I always think about those chronic effects, especially in older folks, the cognitive issues, the bone health. It often just gets chalked up to aging, right? But it might actually be the chronic low sodium. Why does that happen? Why does persistent, even mild hyponatremia cause more falls and affect bones?
Yeah, it's an important point. It seems to be multifactorial. There are subtle changes happening at the cellular level. So first, that chronic mild hyponatremia, it's linked pretty clearly to cognitive impairment, maybe some mild confusion, and gait instability. That directly increases fall risk. We think it might be due to sort of chronic low-level brain cell swelling or just impaired neuronal function from the osmotic stress. And second, and this is maybe the more surprising part, is the effect on bone. Chronic SIADH seems to promote bone mineral density loss. It leads towards osteoporosis and definitely increases fracture risk, independent of the falls. The thinking is the hyponatremia itself might directly mess with osteoclast activity or perhaps calcium handling, maybe due to that constant osmotic stress within the bone matrix itself. So catching it early isn't just about fixing the number, it's about preventing this sort of silent long-term damage. Okay, so if we want to manage it effectively, it helps to quickly review the core mechanism again. It all comes down to that persistent non-osmotic ADP release. And AVP acts specifically on those V2 receptors located in the collecting ducts of the kidney.
Right. And when AVP binds to those V2 receptors, it kicks off this intracellular cascade, the result being more aquaporin 2 channels getting inserted into the cell membrane, the part facing the urine. These aquaporins, they're basically water channels. So you get this aggressive, unregulated reabsorption of free water back into the body out of the urine. This directly expands the total body water, the TBW, relative to the body's sodium and potassium stores.
That expansion is the absolute key. If you think back to the Edelman equation, which sort of governs serum sodium concentration is basically driven by the ratio of total exchangeable sodium and potassium, that's the numerator, divided by total body water, the denominator. In SIADH, the numerator, the total amount of sodium and potassium, is usually pretty normal. They're not salt depleted. But the denominator, the total body water, is way up because of all the inappropriate water retention. So mathematically, that ratio drops, leading directly to the dilutional hyponatremia.
And this physiology gives us those classic lab findings we need to look for, the ones that help confirm the diagnosis. So first, you need hypotonic hyponatremia. The serum osmolality has to be low, usually under 275 milliosmoles per kilogram. Second, and this is crucial, you need evidence that the kidneys are doing something inappropriate. The urine should be concentrated, typically a urine osmolality over 100.
Right, over 100,
Yeah.
despite the serum being dilute. That's the inappropriate part in action. Third finding is natriuresis, the presence of sodium in the urine. We usually see a urine sodium concentration greater than 30 millimoles per liter. This reflects the body trying to compensate for the slight volume expansion by getting rid of some sodium, but because AVP is trapping the water, they end up losing sodium without enough water following it. And fourth, this isn't a lab test, but it's critical. The physical exam must confirm clinical euvolemia. You have to actively look and document. No signs of volume depletion, no orthostasis, good skin turgor, and also no signs of volume overload, no peripheral edema, no JVD, no ascites.
Okay, so we know the mechanism involves ADP. Clinically, when we suspect SIADH, what are we actually looking for as the underlying cause? The workup target. The list of possible etiologies in hospitalized patients is huge, so we need a structured approach. Malignancies are definitely high on that list. Small cell lung cancer, SCLC, that's the classic one.
Yeah, SCLC is the textbook example of ectopic AVP production. The tumor cells themselves are actually making and secreting AVP. It's completely outside the normal pituitary control. That's why treating the cancer itself is often the only way to really resolve the SIADH in those cases. But it's not just SCLC. You have to think about other lung cancers, other thoracic tumors, mediastinal masses too.
And beyond cancers, lung problems in general are common triggers. This could be infections like a bad pneumonia or TB, but also non-infectious stuff that irritates the lungs. Think acute respiratory failure, a severe asthma flare.
The idea there is that inflammation or irritation in the lung sends signals, maybe via the vagus nerve, back to the hypothalamus, inappropriately triggering ADP release. And then there's the brain. Any significant process affecting the central nervous system, the CNS, can do it. We're talking brain tumors, infections like meningitis or encephalitis, strokes, significant head injuries. Even things like the stress and inflammation right after pituitary surgery can be a trigger.
And we absolutely cannot forget drug-induced SIADH. This has become arguably one of the biggest contributors, especially with polypharmacy. SSRIs, the selective serotonin reuptake inhibitors, they're notorious for this.
Yep.
But the list is long. Antipsychotics, older tricyclic antidepressants, certain chemotherapy drugs.
Let's just pause on the SSRIs for a sec because they are so common. How do they do it? It's usually not by directly making more AVP. It's thought they might increase the kidney's sensitivity to the existing AVP, or maybe they enhance AVP release from the pituitary gland, kind of lowering the threshold for release. Often a bit of both.
Yeah.
You mentioned chemo. Yeah, things like vincristine, cyclophosphamide. Those are well-known culprits. They can directly stimulate AVP release or potentially cause some kidney effects. Oh, and don't forget opiates. They're known AVP stimulants. And even vasopressin analogs we sometimes give therapeutically, like for GI bleeds.
Right. And then there are the more transient things, post-op SAIDs, severe nausea or vomiting, significant pain, just general stress, even anesthesia itself. Any of these can cause a temporary non-osmotic AVP surge that usually resolves once the stressor is gone.
And finally, very rarely, you can have genetic causes. These gain-of-function mutations in the V2 receptor itself, sometimes called nephrogenic SIADH, where the receptor is just stuck in the on position, even without AVP. Very uncommon, but worth knowing exists. So given all these possibilities and the risk of getting it wrong, like mistaking SIADH for dehydration and giving the wrong fluids, which can be disastrous, we always have to come back to the diagnostic bedrock, the Barter and Schwartz criteria. Systematically applying all 6 is key for accuracy.
Absolutely. That checklist is non-negotiable for us as hospitalists. Let's run through them again quickly. 1, hypotonic hyponatremia, low serum osmolality, check. 2, inappropriately concentrated urine osmolality 100, check. 3, natriuresis, urine sodium 30, check. 4, clinical euvolemia on exam, check. 5, exclusion of other causes, specifically secondary adrenal insufficiency, think cortisol levels, check. 6, also exclusion of severe hypothyroidism, significant renal failure, and recent diuretic use, check.
Right.
It's truly a diagnosis built on careful exclusion.
And to help with that tricky exclusion part, especially telling SIADH apart from true hypokalemia, some supporting lab findings can be really helpful. The classic ones here are hyperosemia, a low serum uric acid, usually less than 4 milligrams per deciliter, and often a low BUN, blood urea nitrogen.
Yeah, those are powerful clues. Why are they low on SIADH? It relates back to that effective volume status, right? In euvolemic SIADH, you have this relative expansion of total body water. This increases the delivery of fluid and solutes to the proximal tubule in the kidney. And that increased flow sort of washes out solutes like uric acid and urea, reducing their reabsorption back into the blood.
Exactly. Contrast that with true hypovolemic hyponatremia. In that state, the patient is volume down, the renin-angiotensin system is fired up, and this leads to increased proximal tubular reabsorption of water and solutes trying to conserve volume. So in hypovolemia, the BUN and uric acid tend to be normal or even high. So seeing low BUN and low uric acid alongside hyponatremia should definitely make you lean towards a euvolemic state like SIADH.
Okay, here's a practical point. Should we be ordering plasma AVP levels? I feel like sometimes people want to order it, but is it actually useful?
Generally, no. It's not recommended and honestly not very helpful in most clinical situations. Measuring ADP is technically difficult, it's slow, it's expensive, and the evidence shows the level itself doesn't reliably distinguish SIADH from, say, volume depletion, because AVP should be high in volume depletion. It's physiologically appropriate then. So the diagnosis really hinges on seeing the effects of AVP, the concentrated urine, the natriuresis happening when the patient is clearly euvolemic, not on the AVP level itself.
But let's be real. In the middle of a busy shift, assessing volume status purely by exam can be tough, right? Sometimes patients are just borderline. You're not entirely sure. Is there any objective test that can help when the physical exam is ambiguous?
That's a great question, and it's where some, let's say, more dynamic or advanced testing might come in. This is an area getting more attention. There's some decent data now, some published in scientific reports, looking at post-saline infusion urine sodium. The idea is if you're really unsure about volume status, you give a small, controlled bolus of isotonic saline, maybe 500 cc or a liter, and then you measure the urine sodium concentration afterwards.
Interesting. What are you looking for there? How does that help differentiate?
Well, think about it. If the patient is truly hypovolemic, their kidneys should be avidly trying to hold on sodium. So after a saline bolus, their urine sodium should remain low as they reabsorb it all. But if they have SIADH, their kidneys are already inappropriately dumping sodium because of the perceived volume expansion. Give them more saline, and they'll just keep excreting a large fraction of that sodium load. Some studies suggest a post-infusion urine sodium cutoff, maybe around 24.5 milliball or higher, has pretty good specificity for SIADH versus hypovolemia in those ambiguous cases. It helps confirm that inappropriate renal sodium handling. And of course, while imaging like a chest x-ray or maybe a brain MRI isn't strictly needed for the diagnosis of SIADH itself, it's absolutely vital for the etiology workup once you suspect SIADH. You have to look for those underlying causes, especially cancer or CNS lesions.
Okay, let's shift gears to management. Once we've made the diagnosis, what's the approach? The initial steps seem pretty universal, regardless of how low the sodium is. Priority number one always is find and treat the underlying cause if possible. Stop the offending drug, treat the pneumonia, manage the tumor.
Absolutely, that's paramount. And right alongside hunting for the cause, you have to immediately stop any hypotonic fluids the patient might be getting. D5W, half-normal saline-free water intake. Got to cut that off. But here's the really critical point, the one that still trips people up all the time. Giving isotonic saline, normal saline, 0.9% ACL, might not just fail to help in SIADH, it can actually make the hyponatremia worse.
Right, let's really hammer this home. It seems counterintuitive. You have low sodium, why wouldn't giving sodium help? Explain that paradox again.
Okay, it boils down to the kidney's behavior in SIADH and osmolality gradients. Remember, in SIADH, the urine is inappropriately concentrated, often well above 100 mAs of mercury, sometimes 400, 500, even higher. Now, isotonic saline has an osmolality of about 308 mAs of ml. If your patient's urine osmolality is, let's say, 500 mAs of media, meaning their urine is more concentrated than the saline you're infusing, what happens?
The kidney gets the sodium and chloride from the saline, but because AVP is still active, it forces the kidney to reabsorb more free water than is needed to excrete that solute load.
Precisely. You're essentially giving the kidney more solute, NaCl, which it then efficiently excretes in a concentrated urine. To excrete that extra solute load at a high concentration, like 500 UOS/mO/CEG, the kidney actually needs less water than you gave it in the isotonic saline. So the net effect is excretion of a smaller volume of highly concentrated urine, leaving behind excess free water in the body, which further dilutes the serum sodium. You end up retaining free water from the isotonic saline. This is exactly why we need to use that calculation, the ratio of urine, sodium plus potassium, to serum sodium, to predict response and guide therapy, especially fluid restriction.
Okay, let's talk about the scary situation. Severe symptomatic hyponatremia. The patient is seizing, comatose, having respiratory issues. This is an emergency.
Absolutely medical emergency. It requires immediate, decisive action. The standard here is hypertonic saline, 3% sodium chloride. We typically give it as a 100 to 150 millibio IV bolus. You can repeat that bolus maybe once or twice more, say every 10, 20 minutes, depending on the clinical response. The immediate goal is rapid but controlled correction. You want to raise the serum sodium fairly quickly, maybe by 4 to 6 millimoles per liter, just in those first couple of hours. That's usually enough to pull water out of the brain cells and reverse the acute cerebral edema causing the symptoms. And definitely get help. Consult nephrology, consult critical care. This needs close monitoring and expert management.
And we cannot stress enough the safety limits here. Overcorrecting too fast is catastrophic. It leads to osmotic demyelination syndrome, ODS, which can cause irreversible neurological damage. The absolute limits, the hard stops, do not raise the sodium by more than 10 millimole in the first 24 hours. Ideally, aim for less, maybe 6 to 8.
Yeah, 8's a good target.
And no more than 18 millimole total over 48 hours. These are non-negotiable.
Right. The risk of ODS is very real, especially if the hyponatremia was chronic before this acute worsening. And we've all seen it happen, right? You have someone with severe hyponatremia, you give a couple of boluses of 3% saline, maybe you start treating the underlying pneumonia, and suddenly the kidneys wake up. The SIADH resolves rapidly, and the sodium shoots up 12, 15 points in just a few hours. The crucial move, then, isn't just stopping the hypertonic saline. You have to actively prevent further water loss. You need to intervene to stop the overcorrection.
How do you do that? What's the practical step to slam the brakes?
You give desmopressin, DDAVP. It sounds paradoxical giving an AVP analog when the problem was too much AVP effect. But what DDAVP does is it provides a stable, predictable level of V2 receptor stimulation. It effectively puts the kidneys back into a controlled state of water retention, stopping the uncontrolled free water loss. It clamps the water excretion. Once you've given DDAVP to stabilize the situation, you can then, if needed, carefully give hypotonic fluid, like D5W, to gently bring the sodium back down into the safe correction range if it overshot. This DDAVP clamp strategy for managing or preventing overcorrection is absolutely vital. Every hospitalist needs to be comfortable with it.
Okay, shifting back to the more common scenario. The patient with moderate hyponatremia, maybe sodium 120 to 129, perhaps mild symptoms like some nausea or just feeling off, not seizing, not comatose. Here, the traditional first-line approach is fluid restriction, usually aiming for somewhere between 500 milliliter and 1 liter per day total intake.
Yeah, fluid restriction is the historical go-to. It's simple, it's free, no drugs involved. But we really have to acknowledge its limitations. It frequently fails. There was data from the hyponatremia registry that was pretty eye-opening. It showed that more than half, over 50% of patients treated with just fluid restriction didn't get a meaningful rise in their sodium, which they defined as 5 mUqL or more.
So if it fails so often, why is it still first line? Is it just inertia, or does it actually work for some specific patients?
It's probably a bit of both. There's definitely inertia, but it can work, just not for everyone. Fluid restriction is only going to be effective if the patient's kidneys can actually excrete more free water than the amount of water they're taking in. It works poorly, or not at all, in patients who have very concentrated urine with a high solute load. In those cases, the kidney is just too efficient at holding on to water because of the SIADH. That's precisely why we need to tailor the approach using that urine to serum electrolyte ratio, the sum of urine sodium plus urine potassium divided by the serum sodium.
Right. Tell us more about how that ratio helps predict success and guide how strict the restriction needs to be.
Okay, so this ratio gives you a physiological snapshot of how effectively the kidneys are excreting solute-free water. If that ratio, urine A plus K, serum A, is low, let's say significantly less than 1, maybe 0.5 or less, it suggests the kidneys are relatively capable of excreting free water. These patients are the ones most likely to respond to fluid restriction. You might start with a more liberal restriction, maybe 1.2 or 1.5 liters a day. But if that ratio is high, say approaching 1 or even greater than 1, that tells you the kidneys are maximally conserving water relative to solute. They're making very concentrated urine. In these patients, fluid restriction is almost certainly going to fail. You need an incredibly strict restriction, probably less than 1 liter, maybe even less than 800 milliliters a day, which is hard for patients to tolerate. Honestly, if the ratio is high, you should probably just anticipate failure and move more quickly to a second-line therapy instead of waiting days for the fluid restriction to not work. It just delays effective treatment. which logically brings us to those second-line therapies.
What do we do when fluid restriction isn't appropriate because the ratio is high, or when we've tried it for 24, maybe 48 hours, and it's just not working?
The first option here, and one that's gaining a lot of traction, is oral urea. Dosing is usually somewhere between 15 and 60 grams per day, often started maybe 15 grams twice a day.
Yeah, oral urea is really interesting. Its mechanism is quite elegant in this setting. Urea acts as an osmotic agent within the renal tubules. It basically forces the excretion of water, along with it an osmotic diuresis, but primarily of water. It increases free water clearance. Unlike loop diuretics, which can cause significant potassium loss or even kidney injury, urea tends to promote water loss much more selectively without messing up electrolytes too much. The result is usually a pretty predictable and sustained rise in serum sodium.
And what's the evidence look like for urea? How effective is it compared to, say, doing nothing or other options?
The data is getting stronger. Recent systematic reviews and meta-analyses look quite positive. They show that oral urea typically increases serum sodium by a respectable amount. The mean increase is often around 9 mQi in studies. That's clinically significant. And importantly, its efficacy seems comparable to the Vaptans, those more potent drugs we'll discuss, and definitely better than placebo or just continuing failed fluid restriction.
Okay, so if it works well and the main side effect seems to be just that it tastes bad, why isn't it used more often? Why isn't it the automatic go-to second-line agent everywhere?
That's a great question. I think it's a mix of things. There's definitely less familiarity compared to, say, diuretics or even Vaptans in some centers. The palatability is a real issue. It can be hard for patients to take consistently. Mixing it with juice, maybe some lemon, or using flavor formulations can help. Sometimes it needs to go down an NG tube if the patient can't tolerate it orally. There's also maybe some historical inertia or perhaps a lack of big pharma-sponsored trials compared to newer agents. But it's telling that the European Renal Association, ERA, now explicitly recommends urea as a second-line option, really based on its effectiveness and safety profile, even without those massive RCTs. That's a strong endorsement.
Okay, let's contrast urea with the more traditional, maybe slightly older second-line approach, combining salt tablets with a loop diuretic like furosemide.
All right, the salt tab and loop strategy. The idea here is twofold. Increase the total daily solute load the kidneys need to excrete by giving extra salt, usually 2 to 5 grams a day, and simultaneously use the loop diuretic to impair the kidney's ability to concentrate the urine in the loop of Henle. You're essentially trying to force a less concentrated urine, promoting excretion of both salt and water. But the data here is honestly not great. Randomized trials show the benefit is often pretty modest and sometimes doesn't last. And importantly, this combo comes with real risks. You significantly increase the chance of causing acute kidney injury, AKI, from volume depletion if you overshoot, and hypokalemia is very common with a loop diuretic. So it really needs careful patient selection and close monitoring. It's probably best reserved for specific situations where urea or Vaptans aren't options or haven't worked.
Right, now for the heavy hitters, the vasopressin receptor antagonists, the Vaptans. Tolvaptan is the main one we use orally. Starting dose usually 7.5 or 15 milligrams daily.
Yes. Tolvaptan is a selective V2 receptor blocker. It directly antagonizes AVP's action right at the collecting duct. This leads to what's called aquariocyst excretion of large volumes of electrolyte-free water. It directly targets the problem in SIADH. It's incredibly effective, no doubt about it. It can rapidly increase serum sodium, and there's some evidence it might even shorten hospital stays because it works so quickly. It's generally reserved for more refractory or severe chronic cases.
But there are significant downsides, right? Safety concerns, monitoring cost.
Huge caveats. The biggest is the risk of overly rapid correction of sodium. Because it's so potent, it can cause the sodium to rise too quickly, putting the patient right back at risk for ODS. Its potency means you absolutely must monitor sodium levels very closely, especially when starting the drug off in only 6 to 8 hours for the first day or two. This frequently requires admission to a monitored setting, adding complexity and cost. And crucially, you cannot use tolvaptan if the patient is also getting hypertonic saline. The combined effect would almost guarantee dangerous overcorrection. So yes, it's highly effective, but the cost, the intense monitoring requirements, and the safety profile mean it's really reserved for those truly resistant cases of SIADH where other options like fluid restriction or urea have failed or aren't feasible.
We should also touch on context. What about patients where the SIADH is due to something like advanced cancer or end-stage heart failure? The goals might be different there.
Absolutely. In those palliative situations, or where the underlying cause isn't fixable, the goal often shifts. It's less about curing the SIADH and more about managing the symptoms of hyponatremia. We aim to keep the sodium at a level that improves quality of life, reduces nausea or confusion, maybe prevents hospitalization, rather than striving for perfect normalization if the underlying disease is progressive. Therapies like urea or even low-dose Vaptans might play a role here for symptom control.
And are there any other emerging therapies on the horizon?
Well, there's some interest in SGLT2 inhibitors, drugs like empagliflozin or dapagliflozin, usually used for diabetes or heart failure. They work by making you excrete glucose in the urine, which causes an osmotic diuresis, pulling water out with the glucose. Mechanistically, it makes sense that this could help excrete free water in SIADH, but the actual clinical data specifically for SIADH is still pretty limited. They're not standard care for this indication yet, but it's an area to watch.
And just to be thorough, older drugs like dimethyl or lithium, we don't really use those much anymore, do we?
Very rarely. They do interfere with AVP action at the kidney level, but they both have significant toxicity concerns, especially kidney toxicity with dimethyl and the narrow therapeutic window and side effects of lithium. Generally, they've been replaced by safer options like urea or Vaptans when needed. Okay, so treatment is initiated, but the job isn't done. Monitoring is just as vital as choosing the right therapy, especially for safety. Preventing ODS by avoiding overly rapid correction has to be the top priority during the active treatment phase. So a strict monitoring protocol is absolutely mandatory.
Right. How often should we be checking sodium levels? It depends on the situation, doesn't it?
It absolutely does. If you're actively correcting, particularly if the starting sodium was very low, say below 120, or if you're using potent therapies like hypertonic saline or avalotam, you need frequent checks. Serum sodium every 6 to 8 hours is standard in that acute phase. You cannot afford to miss a rapid rise.
Yeah, no question.
Once things are stabilizing, maybe the patient is responding well to fluid restriction or they're on a stable dose of urea, you can back off. Daily checks are usually sufficient until the sodium is stable in the target range. Then for chronic management, maybe outpatient, might be checking 2 or 3 times a week initially, then less often once stability is confirmed.
And it's not just about the number on the lab report. We need to be assessing the patient clinically too, right?
Constantly. Regular neurological checks are vital during active correction. Are they getting less confused? Great. Are they developing a headache, nausea, new focal deficits? That could be an early sign of ODS if correction's too fast. You need to catch that immediately.
What else should we monitor besides sodium and neurostatus?
Definitely keep an eye on renal function, BUN, and creatinine. Also potassium levels, especially if loop diuretics are involved, as hypokalemia is a risk. Tracking uric acid can also be helpful diagnostically, as we discussed, and seeing it rise might indicate resolution of SIADH or perhaps development of volume depletion. So yeah, BMPs or equivalent panels are needed frequently during active management.
And the final point on monitoring is just ongoing reevaluation. The reason for the SIADH might change, or the patient's condition might evolve during their hospital stay.
Exactly. SIADH isn't always static. The underlying cause might resolve. Maybe the pneumonia gets better, the pain is controlled, the drug is stopped. That can lead to a sudden resolution of the SIADH and a risk of overly rapid self-correction if you're not watching. Or their volume status could change for other reasons, poor intake, diarrhea. A patient who had euvolemic SIADH yesterday could become hypovolemic today, requiring a complete shift in fluid strategy. So you have to keep reassessing the patient, their volume status, their labs, and thinking critically about whether the current diagnosis and management plan still fits. Okay, so let's try to wrap this up. To summarize this deep dive, I think the main takeaway on diagnosis is that SIADH is fundamentally a diagnosis of careful, rigorous exclusion. It's anchored by those 6 Barter and Schwartz criteria and really supported by those helpful differentiating labs like a low uric acid and a low BUN pointing towards euvolemia.
And for management, it absolutely has to be severity-driven. Hypertonic saline is for true emergency seizures, coma with specialist input and meticulous monitoring to avoid ODS. We need that DDAVP rescue plan ready for overcorrection. For the more common non-emergent cases, fluid restriction is still technically first line, but we have to be smarter about it. Use that urine NA plus K to serum NA ratio to predict who will fail, especially those with highly concentrated urine, and don't wait too long to move on if it's not working.
Right, and that recognition that fluid restriction often fails forces us to be comfortable with second-line therapies. Oral urea is really emerging strongly here. The evidence shows it's effective, it's quite safe, generally well tolerated apart from the taste, And importantly, it's cost-effective. Its efficacy looks comparable to Vaptins in many studies. Vaptins like tolvaptan are definitely powerful and have their place for refractory cases, but the high cost, the need for intense monitoring, and the real risk of overcorrection limit their routine use. They remain reserved for specific, challenging situations.
So that brings us to a final thought, something for our listeners, our colleagues, to consider as they go back to the wards. Given this growing body of evidence showing oral urea is effective, safe, and much cheaper than Vaptins, especially considering the complexities and costs tied to Vaptin monitoring, how should we as clinicians and maybe hospital leaders think about adjusting our local hospital formularies and our treatment protocols? Should we be pushing to make oral urea a more standard, easily accessible, perhaps preferred second-line agent for managing persistent SIADH, moving it beyond just a specialty item and into the routine toolkit for hospital medicine? Something to think about.